Good morning, my name is Michal Kalina, I'm anesthesiologist in Děčín Hospital and in Ústí nad Labem in Czech Republic, and my biggest interest is in adequacy of anesthesia concept, which I will talk about today. I must thank to organizers for inviting me to this congress, and I'm very happy that I can share my view on the adequacy of anesthesia concept. This is my hospital in Děčín, where we push forward the AOA concept in Czech Republic. We do a lot of bariatric surgeries and a lot of bowel surgeries, and we use AOA concept for mostly all of the procedures that we do in this hospital. The same is in hospital in Ústí, where I work as well, where we use AOA concept for thoracic surgeries, neurosurgeries, and some vessel surgeries as well, and also for plastic surgeries. I must declare that I have conflict of interest. I have received research funding from Krajská zdravotní, which is the owner of the two hospitals I work for, and the research funding is not related to AOA concept, but I have a consultancy agreement with GEHC and with Medisub, which is Czech distributor for AOA concept, and GEHC is a developer and distributor worldwide for devices that can be used for AOA concept. And to outline of my presentation, I will talk about antinociception and how we can monitor antinociception. Then I will talk about amnesia and unconsciousness and how we can monitor amnesia and unconsciousness, and what should be our goals and what we would like to achieve with the monitoring. Then I will talk about immobility and the monitoring of immobility, and after all I will talk about adequacy of anesthesia concept as a whole package of the monitoring devices and opportunities and goals that we should achieve. First of all, we should say something about about anesthesia in general. Anesthesia from AOA concept point of view is not just one modality, but we should focus on several parts of anesthesia. One is amnesia and unconsciousness. These are cortical components, and then we have subcortical components of anesthesia, which is antinociception, immobility, and autonomic stability. This concept is not that new, but in last years, this concept is much more in sight of clinicians. The first article about viewing the anesthesia this way of several modalities and about splitting these modalities to solve parts is from this journal, Critical Reviews in Biomedical Engineering. And it's interesting that the biomedical engineers were the first ones who would like to widen the monitoring during anesthesia and to monitor every part of anesthesia separately and to provide more individual care to patients. And you can see that it's year 2002, so it's more than 20 years old concept now. We should talk about the parts separately, so we can start with antinociception. Antinociception is a subcortical part of anesthesia, and what we have for monitoring is SPI, surgical pleth index, and SPI is calculated from the beat-to-beat pulse rate variation, and it can reach values from 0 to 100. 0 is very rarely seen, and the optimum value is between 30 and 50, and we should also look for trends, and as SPI is getting higher, we can interpret it as increasing in pain activation. How is SPI calculated? This is very important to know because we should know what is influencing this value. This value is calculated as heart rate. You can see the formula on the bottom of the slide. So if we use any medication that is influencing heart rate, we must consider that there can be some differences in SPI values not related just to pain. Also, we should beware that in the formula is also the vascular tone, so, or vasoconstriction. So if we are using some drugs that can influence vascular tone, mainly vasoconstrictors, the SPI value will also change. So that are the most common conditions that can influence SPI, and we should be aware that these conditions can change the value, and we should interpret the value according to the clinical scenario that we are observing. What is important to know about SPI is that in large studies, one is from anesthesiology and the second one is from BGA. If we compare the standard care without SPI, just monitoring the pain by physiological parameters like heart rate or blood pressure or breathing frequency, in comparison with SPI, if we use SPI, the dosage of drugs or analgesics is lower in comparison with the standard monitoring. Both studies didn't show any clinical impact on the patient, but as we can interpret these findings as the clinical situation of the patients were the same compared to monitoring SPI or standard monitoring, but in SPI group with lower analgesics consumption, then we can interpret as beneficial to use SPI to lower the dosage, because we know from other studies that as lower dosage of analgesics, mainly opioids, then the clinical outcome for the patients should be better. For sure, we have some more tools to monitor pain. One tool is entropy, and we can come across some studies that are suggesting that using the difference between state and response entropy and its change can show some changes in pain management. But again, as we compare response entropy difference and state entropy and SPI, the SPI is superior for pain monitoring. What can be SPI used also, not just for intraoperative monitoring of pain, but also there are some suggestions that SPI can predict the consumption and the needs for analgesics in post-operative period. This study is done in children patients, but there are studies also made on adult patients, and the result was that if we measure the SPI in patients before general anesthesia induction and the SPI is high, the prediction for higher dosage of analgesics need in post-operative period is higher. So we can predict and change management of some patients that are likely to have problematics with pain control after the surgery. Then from amnesia we can move from analgesia we can move to amnesia and unconsciousness. The unconsciousness and amnesia is monitored with entropy, mostly in my hospitals, because we do the AOA concept, and this is the part of AOA concept. You can see how the entropy is displayed in the monitor, and the first one is the response entropy, and the second one is state entropy, which differs only by EMG from musculus frontalis, and that's why the response entropy is always a higher number. We should also have in mind that how entropies work is that it's measuring the electric activity of the brain, and it's counting the spectrum of different waves, and according to these spectrograms it's calculating the numbers, the response and the state entropy to make the interpretation much more easier for clinicians. And that's one big advantage of using entropy for monitoring the amnesia and unconsciousness. As you can see, the spectrograms differs for several drugs, and the best use of entropy is for propofol and sevoflurane, as these two have very similar spectrograms. If we are using ketamine or dexmedetomidine, the spectrograms differ, and then the values that we see from entropy will be different as well, and will be very difficult to interpret. And what should be the goal for entropy? We should always, or the recommendation says that we should be somewhere between 40 and 60 of state entropy during general anesthesia, but we should also know that these benchmarks can differ or differs depending on gender and depending on the age of the patient and the biological status of the patient as well. So these values can be quite individual, and that's why we should also use not just the number from the entropy, but also see the curve that can show us some more information. As you can see under the propofol and sevoflurane, you can see the curve how it should look like during general anesthesia in mid sedation depth. How we always set the monitoring of the entropy. We also show the curve as I said before. We change the voltage to 100 microvolts because that's the scale of the curve that can be interpreted quite easily, and we always see burst suppression ratio. Burst suppression ratio should be always 0, as we can see on the bottom of the screen, because burst suppression ratio shows us the percentage of time where there is burst suppression on the curve. We want to see the curve also because we know that the burst suppression ratio solely without the curve slightly underestimate the time of duration of the burst suppression ratio, and as the burst suppression is longer and it counts together during general anesthesia, then the clinical outcome in the meaning of some cognitive deficit after anesthesia is higher and the risk is increasing. Here you can see how the burst suppression ratio pattern looks like in the curve, and this pattern is very easy to recognize on the curve when you display the curve of entropy also. Next part of anesthesia is immobility. Immobility is done by neuromuscular blockade agents. We use mainly rocuronium, which is very individually metabolized, and so it's very hard to say if the patient is without residual muscular paralysis, and that's why we always use neuromuscular blockade monitoring. The biggest reason to use neuromuscular blockade monitoring is to exclude residual paralysis, because if there is residual paralysis, increased postoperative complications and mortality is proven. Also, there's increased length of hospital stay, potential patient distress from dyspnea, which is in literature said that it's like the biggest stressful moments for the patients to know what is dyspnea. Also, there is a risk of critical respiratory events in post-anesthesia care, like aspiration or respiratory failure with the need of reintubation. It really depends on what monitoring technique we will choose for muscle relaxant blockade monitoring. In my hospital, we use mainly mechanomyography or electromyography. You can see these two. The mechanomyography, we use like the subgroup kinemyography sensor, and for some procedures we use electromyography sensor. We use electromyography sensors mainly in procedures where we know that there will be very hard to exclude some interventions that can influence the measuring with kinemyography sensor, which can be the placement of the hand or low temperature in the operating room and so on. So in procedures with a high risk of influencing the measurements, we always use electromyography sensors, which is in these situations much more precise, and we can rely on the sensor much better. Also, we did some work on comparing kinemographic sensor, with electromyography sensors, and we come to conclusion that electromyography sensor has much stable measurements, mainly because of the less conditions that can influence the measurement. I would like to point out two very good papers, and both are focusing on managing neuromuscular blockade in general anesthesia. They are both very recent, from 2023. One is from European Journal and the second one is from Anaesthesiology. And what should be told about both those papers: the electromyography is not that pushed in these two papers, even though even though we believe that the electromyography is much stable and much more precise than the other technology that we can use, and it's mainly, as I said, because of the less conditions that can influence the measurement. So if you read these two papers, you should always have in mind that electromyography is, I would say, superior to other methods that we can use for measuring neuromuscular blockade. And now we should put all these monitoring techniques together and create the adequacy of anesthesia concept monitoring. As I said, the first paper about this concept was in Critical Reviews in Biomedical Engineering, and it was in 2002, and now it's more than 20 years, and we have the tool that is described in this paper. And you can see how the tool looks like. We have the amnesia and unconsciousness entropy monitoring, we have analgesic monitoring, SPI, and we have the immobility monitoring, the NMT, using our electrosensor or kinemography sensor. And on the top we have the AOA graph, this 1 minute status, and we can see the point. On the left axis there's state entropy, and in the y-axis there's SPI. So we should always be with the point of our or with our status of anesthesia in left down quadrant, and maybe slightly to the middle of the graph. And what's the beneficial of this graph is that you can see very clearly the changes of the anesthesia, and you can see how stable the anesthesia is. Our goal should be to have as stable anesthesia as can be, so the trajectory of the point should be in a small circle and should not change in time. If there is a change in time in 1 minute status, we know for sure that there is some change in clinical condition of the patient, and we should change some part of the anesthesia that is outlying from the middle of the graph. And is it needed to use the AOA concept in general anesthesia? This work showed that we should use the AOA concept, and it's mainly because, again, because of the reduction of the use of anesthetic agents, propofol and opioids, and also there was a shorter emergence time in the general anesthesia, and the patients that were in the group where AOA concept was used spent less time in post-anesthetic care unit. And all these are signs that AOA concept is beneficial for the patients, even though we don't have a large mortality study of using AOA concept with the impact on the mortality at all. And this is how it looks like in clinical practice. You can see that this is the monitor that we used in hospitals where I work, and you can see on the left side that there's AOA part with the AOA graph, with the point in the middle of the graph with trajectory that is oscillating around the middle of the graph, with the measuring of entropy, SPI, and NMT. And the biggest benefit of this method is that I have all the information I need in one monitor. I don't need any other device, and also I have the 1 minute status graph where my anesthesia is heading to, and if there was any change of anesthesia and clinical condition of my patient. Thank you for your attention, and if you have any questions, you can contact me on this email, michal.kalina at kizcr.eu. Thank you, and enjoy the rest of the Congress.